Well, hello, everyone, and I want to welcome you to today's program. It's on the CMS, Centers for Medicare and Medicaid, Conditions of Participation for Hospitals, and we're talking about the medical records section. Now, this is somewhat of a busy section within the manual because it covers everything from medical care to nursing care to informed consent. So it's really quite a busy section. So why are we here today? So you don't get one of these, of course. That's a statement of deficiencies and plan of correction. That's what you have to do when CMS finds that you did not meet certain conditions and sometimes certain standards, depending what those standards are. CMS will take care of it, and then you don't get paid for taking care of those patients. The manual first started out back in 1986. That's when they first published the regulations. And they've split them into sections called tag numbers. It goes from 1 to almost, well, you're well up into the 1700s for Appendix A. So to keep up with all of the changes, actually subscribe to the Federal Register because that will keep you up to date on new regulations and new rulemaking that is coming out. And you also want to keep an eye on the memos. Now, these are called the policy and memos to states and regions. It is directed to the surveyors. So here's what we're going to talk about today. This is the overall manual. This is the appendix for the manual. We're going to start in Appendix A for hospitals. After that, then I will address Appendix W, critical access hospitals. So what about these deficiencies, these citations, or however you want to refer to them? Now, if you don't like Excel, you can do it by paragraph form. Well, let's start talking about compliance and joint commission. TJC is also known as a joint commission. All right, let's start talking about CMS. Now, I put in here standards of care and practice. Overall, CMS will not establish a standard of care for health, for provision of care. Now, I'm going to cover some changes that CMS put into effect. This went back into effect in 2019. So access. Let's talk access versus authorization. I'm going to talk interoperability and the patient access rule. Information blocking. What in the heck is information blocking? Then there's the security exception. And then there's the infeasibility exception. It's not blocking when trying to fulfill a patient's request. So as far as responding to those requests, if you don't fulfill a request, you have to give them a reason to notice. And you have to do it within 10 business days of getting that request. All right, let's go ahead and talk about texting. That's what we're doing now. Everybody text. Now you think, when are we going to get to the conditions? We're getting there, trust me. All right, I said we were going to get to the conditions, and here we go. So these are all for Appendix A. Services. This is the overall services. You have to have a medical record service. Now, there is a security risk assessment tool. It's out there. Get it and use it. As far as discharge summary, we all know that if you have a lot of people coming back in, the surveyor is going to make sure your policies are there and there's information on how to limit access and disclosure. Records must only be seen by those who have a part in the patient's care. Immediate notification to victims of all breaches. So low probability, these are the objective risk factors. Verbal orders must be dated, timed, authenticated promptly. Standing orders, you can use them, that's fine. Because there's also menu options because not all pre-printed and electronic order sets are considered standing orders that are covered by the regulation. Now, what you can do as far as the update, you have options. This expands the number of categories also of people who can do the history and physical, as long as your state law and your policies allow it. Then there's optional elements. These are what they call a well-designed consent form. Now, there are multiple other sections that pertain to health management, and there should be documentation for the following. I mentioned I would separate out critical access hospitals. These are your conditions for your clinical records. The record must include enough information to justify the admission and support the diagnosis. For history and physicals, you can delegate any part of it as long as it's permitted by state law and your policy and procedure. Codes, signatures. You have to have that list of those codes and signatures. And again, these happen to be some of the federal and state retentions. We know what happens. CMS, Office of Inspector General, OIG, they investigate fraud and abuse. So here's CMS guidance. It talks about cloning. So with that, I want to thank everybody for participating. Thank you for those who did submit that question. I'm going to go ahead and close this out for today. So thank you for attending. And this will conclude our program.